itself and then disappears. So it's not a successful virus, but it's very deadly. But HIV becomes chronic and maintains itself, and that's why it's a successful virus. And once you get that kind of virus, you have a problem, and that's why HIV became a problem. But now with this thorough research and phenomenally, exceptionally high quality and high quantity of research worldwide, these measures, intervention measures came into being. And now HIV becomes controlled, manageable, that people are now living a productive life for very long periods in their lives. And
you was telling us that that type of treatment, this combination of drugs that are used, is the highly active antiretroviral therapy.
In short,
which is what you call HAART.
That's right.
And this represented a game changer in HIV treatment.
Absolutely.
So from then onwards, HIV was no longer that big, gigantic problem which everybody was scared of because it was a death sentence.
Exactly, and that's the reason why some people, that was why Kofi Annan was able to really convince some big funders to really provide money and that's how the Global Fund came into being, to really supply drugs so that they could actually manage this disease in poor countries like Africa.
Tell us, what was the long-term expected impact of using HAART? Because from what I understand, it manages to significantly reduce viral loads on the person to the extent that it cannot be, the disease can no longer be transmitted to another person. Yeah, yeah. So eventually, it would eliminate HIV almost to a very, very small scale.
Yes, I would say it will eliminate, because elimination can mean, scientifically can mean something different. But I would say its use has controlled HIV. I would say it's controlled it to a very considerable degree. Many epidemiological research studies after these multiple drug interventions have been carried out in various groups to really show to what extent there's an impact on this intervention, whether you would really have a resurgence, how quickly do you have a resurgence, how quickly can you have mutations against this, and what are they? Then there were some results where you could have resurgence, you could have mutations coming against them for certain types of, HIV has various types because of the mutations I was saying. And then there came what is known as second-line therapy. So clinicians can bring in a second-line therapy where you can actually circumvent the long-term effects of viruses that encode in wall of Dendegarbopa. This is the type that I say, look, I'm just going to make sure, I survive this in this person, and then they will come up. And then consequently more drugs came, and there were more combinations and second line changing, and it becomes, as you said, becomes like diabetes. And not only that, the viral loads get so low that there won't be transmission in the community, and that is really what the game changer means,
Exactly.
And so the epidemic becomes a non-issue. If I can maybe say, now the recent thing is actually, because of the discovery of these drugs, the recent thing is now trying to implement even what is known as PrEP for very highly vulnerable people, such as those sex workers and men who have sex with men, to give what is known as PrEP. PrEP is pre-exposure prophylaxis. And why that? Because the new drug is just recently discovered called cabotegravir, which is, when you give, it has a long-term effect. When you inject it, it has a long-term effect. So when you give it for every 3 months or 4 months, even if you are exposed by somebody who is a viral spreader, you don't get infected. So this is how the treatment has evolved now to really manage HIV.
In a sense, the available treatment for HIV had so significantly advanced that the world of the biggest problems for the world of medicine is no longer HIV.
Absolutely.
So it's other things.
Absolutely.
But this heart treatment, it became available in Gambia, wasn't it?
Yes, it became available shortly after it was proven, I think 2004, around there, where it started available. And as I said, when the Global Fund got established, this facilitated the funding, to African governments so that there will be free access of these drugs.
So pretty much the medication became available for free for people in Gambia who are infected by HIV and AIDS.
Yes.
How were these people? What were the steps taken by MRC to admit these people, to give them access to the heart treatment program? Yes,
well, that's an important question, because we had developed the protocol even long before the heart came in. As I said, alluded to when we started the first treatment trial, starting with the initial drugs. Because they are in the cohort, they've consented to be followed up and to be looked after. We will counsel them on the treatment, but basically, one of the most essential part of this procedure is adherence counseling, because the moment you don't adhere to the drug regimens, you're likely to fail. You as a clinician who is managing, but the patient also will be in jeopardy. So the counseling is there, but then we will also make them accept monitoring. Because no matter how we have confidence that these drugs work, we need to monitor them. And so we develop a clinical database where we will monitor each of the patients that will come into drug. But during that time, there was only some special category that will be enrolled for treatment. The asymptomatic in the cohorts, and asymptomatics are the one in stage 1, and asymptomatic is only maybe those who have antibody positive, maybe occasional lymphadenopathy, but are not they're having good CD4 count, because we monitor all the members of the cohort anyway for CD4 count. If you have high CD4 count, we won't treat you. The reason why you are not treated is because at that time it was scientifically proven that those who are asymptomatic have still a strong immune response and could inherently be fighting well with the virus. And if the drugs can actually make them a little bit weak, to hamper that ability to fight the drug. So we don't treat them, we continue to monitor them. Whereas those who come into stage 3, where they have an unexplained gain loss, weight loss of more than 10% of your presumed or measured body weight, with recurrent viral infections and potential recurrent diarrhea and co-infections. These stage 3, stage 4 most likely will have a CD4 count of at 200 per microliter. And then these people will be started treatment. But we don't start them immediately. There was a committee that was set up in collaboration with with the Gambia government. I think it was the AIDS Secretariat and the CCM, the country coordinating mechanisms through which the Global Fund is administered, I think, at that time. I don't know what is the procedures now, but there was what is known Treatment Eligibility Committee that was created in collaboration with MRC. And these patients who will be selected for treatment because of these parameters, clinical parameters we've observed, will be vetted by the committee before they start the treatment. And then we will start the treatment based on that, but proper counseling, proper adherence advice, and then explanation of the procedures for monitoring CD4 count and viral load.
In a sense, you had to go through all the elements of your established protocol.
Exactly.
Counseling, adherence, screening, advice on opportunistic infections, social and nutritional support before you actually
before we start. So we would know, we will gather parameters that are essential that will help in the management and in the monitoring of that treatment you're doing for each individual patient.
In a sense, you would have to gather all the baseline data that is needed before a person is admitted into the program.
Exactly.
All right. At this stage, I mean, you've talked about the various stages of HIV. It would be important also for the Commission to have an understanding of the differences between HIV and AIDS. Could you give us that explanation?
Oh yeah, that's right. HIV, if you say you are HIV infected, doesn't necessarily mean you are having AIDS. You can be HIV infected and you don't have AIDS. The difference is that HIV infection comes in 4 stages clinically, and this is, you Google WHO clinical guidelines, you will see them. The first stage is called stage 1, where it is where the person is asymptomatic, doesn't have symptoms, but there can be what is known as lymphadenopathy. That's most likely what you would observe. Lymphadenopathy is enlargement of some of the lymph nodes. That's most likely what you may observe. Some you don't even, and they will just be asymptomatic. How do you know they are asymptomatic? They perhaps had an occasional infection here and there, or visit a clinic here and there to complain something, and you happen to test HIV, and then they were positive by antibody. And these people can remain asymptomatic for a period of 3 to 10 years if it is HIV-1, before their CD4 count starts getting affected. In the case of HIV-2, they can remain in that period of asymptomatic for up to 20 years.
Is that the reason why it is said that you can see a seemingly healthy person who is HIV positive?
Absolutely. Absolutely. That's the reason. Because once you get HIV, then in fact you may not just immediately calm down. The body also is constituted in a way that can really fight infections. Despite that, HIV attacks one of the frontline soldiers. And the way the body fights is because it's exactly, I don't know who designed an army, the way army works, but he may perhaps be an immunologist who did that, but it's exactly that's the way immunology works. You have surveillance system, you have a navy, here you have something in the blood that really looks out for something strange, and you have different divisions of different soldiers within the body who have specific roles to play. And this is exactly what the body does when infection comes in. But it's now up to the virus to say how best I'll be tricky enough to overwhelm these people, these different soldiers, or I will allow them to fight me. So this is how it works. So stage 1 is like that with an asymptomatic period. Then the stage 2 is where now the infection starts coming in. It's still not AIDS, but you start having more recurrent respiratory infections because the respiration and perhaps maybe even digestive infections, so that and that will result to diarrhea. The reason is there are lots of microbes in the lung areas and also in the digestive tract. And once immunity starts falling down, these bacteria also turns against you. And that's the reason why you now start getting those kind of infections. But you may not be having AIDS because your CD4 counts are still strong enough. They're still not below 350. It is stage 3 where the CD4 counts have really gone down, and there is an explainable weight loss of more than 10% of your presumed or measured body weight, where you're losing considerable weight and accompanied by severe diarrhea and co-infections happening, etc. And the stage 4 is what is known as HIV wasting. That's when you would see a person and know that this person is really, really sick because it's completely emaciated. And potentially, if you do other infections, it may have concurrent TB or hepatitis B or other co-infections. That's the stage 4, and that's AIDS. 3 and 4 are potentially the AIDS defining, clinical stages. So this is the difference.
But in Gambia, with the protocol that was established, especially the relationship that existed between the members of the cohort and those who are responsible for treating it, you were able to really deal with the situation successfully. Was that the case?
That's the case. Majority of them were treatment success. We had successful treatment. Who you would call treatment success. Treatment failures can happen once in a while in some patients due to one reason or another. Clinically, that can be clinically of a reason, but majority of them were successfully treated and virus suppressed. And those who were towards the stage of 3 and 4 will revert back to behave like stage 1 and 2.
And with all this, you help assist to establish support groups amongst members of the community who were infected. Can you tell us about that? Yes.
Apparently, it was important to give confidence and more trust, engender trust between doctors and who are managing these infections and patients, but also to create some kind of a peer-to-peer support. And one of the phenomenal good things that really happened eventually was the creation of the Santayala group. That came into being, and one of our doctors was highly engaged in that, or one or two actually of our medical clinical doctors was, as I said, I became just the head of the viral disease program and having an oversight management of it, but the real frontline people working with these guys were the clinicians then under my department, and they used to do phenomenal work to establish that trust and relationship. And the creation of the Santayala group, which is the HIV-infected people coming together as a group, I think was fantastic. It really helped the nutritional support, helped the adherence process and everything.
In fact, in your statement at paragraph 10, you said as follows, and I quote, MRC Gambia had a HIV cohort of 1,600 HIV-1 infected individuals as up to 2005. These were clinically taken by MRC HIV clinical staff. Clinical visits would entail monitoring CD4 count, plasma viral load testing, counseling, adherence if on therapy, and periodic field worker visits. There was good relationship between field workers and patients to a level where we encourage support groups. The patients created one support group called Santayala, where there are peer support and nutritional support within them. This is the crux of it.
Yeah.
This was how we were managing HIV in Gambia, to the extent that 90% of the patients had suppressed viral loads with increased CD4 count.
Exactly.
And were doing very well.
Exactly. That's quite right. That's quite right. The treatment was no doubt very successful.
Was there any need to change our approach?
Absolutely not. Not that I see, or not that any scientist would see. Because whatever approach you do has to be based on scientific evidence.
And for those who were not eligible for treatment because they were maybe stage 1. According to your statement, you followed them in your cohort with field workers, and they continued their clinical visits every 3 months.
Exactly.
And during these clinical visits, the array of lab tests were all done, samples were taken, and you made sure that they were okay.
That's absolutely.
Still no necessity of other intervention.
Absolutely.
And then, obviously, these drugs that you were using prolonged the lives of those who participated in the program.
Absolutely.
And the effectiveness of these ARVs were not to be doubted at all.
Absolutely.
In fact, in paragraph 12 of your statement, this is what you had to say. It is important to note that once a person gets HIV-1 or dual infection, there is no other treatment other than ARVs, which should be taken for life.
Yep.
That was why we placed so much emphasis on adherence of treatment and field followers, because patients get tired from taking medication every day and no longer want to take it. When patients' viral loads would come up, it would be as a result of drug-resistant mutations, which is triggered by suboptimal intake of the ARVs. We then would have to implement second-line therapy to save the patient.
Exactly.
The multitude choice of drug combinations make it possible to manage HIV patients adequately for them to have long quality of life. Hence, a gigantic step from the days when HIV was regarded as a death sentence.
Exactly.
So the infection became rather a manageable chronic disease, which allows the patient to have a productive life. This was the situation in 2005. Very effective. You guys did a phenomenal job. Then come January 2007, when our president came with his bag of herbs and made a diabolical pronouncement. We will come to that after the break. Thank you, Mr. Chair.
Thank you.
I'd like that point to take the break and then come back to that. But Dr. Jaye, your remark that whatever you do should be based on scientific evidence, and I presume that evidence comes through one door, training and then knowledge, not through intuition. But anyway, we'll get to that when we come back.
Are you addressing Donald Trump?
See what it is. But thank you again. This is a very good setting for our hearings as we get to the next stage. Thank you very much. We'll take a 30-minute break, come back at 12 noon. Thank you. Meeting is adjourned.
Thank you.